We spent quite a bit of time talking over the normal endocrinology, but I think it's really important to have a pretty firm foundation, or at least an introductory portion of the lecture before we dive into these different types of disorders. Okay? So now we're going to go into kind of the pathological side of things. But if you don't have that framework to begin with, even if it was a while ago, or maybe for some of you it's the first time you've really seen it in that way, hopefully it sets the stage for you to understand and try to be able to track with where things go when we've got a disorder. So we've got different types of categories of endocrine disorders. We can impair the production of the hormone, right? Impair the synthesis. Something's wrong with how it's made. It's either made too much or it's made too little. If there's a hypersecretion, it could be a result of what we call an ectopic foci that's present. So there's a mass that maybe is a neoplasia, it's a lesion, it's growing, and it's getting bigger, but it's got well-defined borders, okay? It resembles the tissue in the brain that it came from. It looks like hypothalamus tissue, or it looks like anterior pituitary tissue, and it makes hormone. And so it makes too much. Does that make sense? So it's not cancer, it's benign, but it's growing, and because there's more tissue there that's making hormone, you get an upregulation of hormone production. You guys, you with me? Or it could be under-secreting. So now the adenoma gets too big. The brain is actually confined by a skull cap, so it can't get too large. If the lesion gets too big and puts pressure on adjacent tissue, it could shut down production of the adjacent tissue. So you might have hyposecretion. You could have abnormal interactions that are happening between the hormone or the target organ, or you could have an abnormal target organ response. It doesn't work correctly. The hormone that's made is non-functional, for example. So it makes hormone, but it doesn't affect the target tissue, for example. That could happen too. So just different broad categories as we move into this. So the first up, tissue-wise, is going to be the hypothalamus. Then we'll get into pituitary, and we'll kind of work our way throughout the different organs. Not all of them, but a few of them. Okay? You had more that you were broadly exposed to in the reading. You had more that you were tested over on the pre-quiz, and you will in the post-quiz. But for purposes of this exam, I'm picking some of the big players for the lecture. And that's what we're going to focus on. Hypothalamus. The main hormones of the hypothalamus are these releasing hormones, like we talked about. So growth hormone, releasing hormone, GHRH. The inhibitory version, growth hormone, inhibitory hormone, is also known as somatostatin. We've got PRF, that's prolactin releasing hormone. PIF, prolactin inhibiting hormone, also referred to as dopamine. Gonadotropin releasing hormone, thyrotropin releasing hormone, and corticotropic releasing hormone, CRH. You can see the anatomy that we were talking about earlier. Here's our thalamus right here. I'm sorry. Here's our thalamus right here, right? And the hypothalamus sits just inferior to it. Hypo meaning underneath or below. And here's our pituitary gland right here. So the hypothalamus is above the pituitary, and the hypothalamus is below the thalamus. Magnified view here, hypothalamus up here, and the pituitary gland right here. You can see the neuronal tracts that extend from the hypothalamus into the posterior pituitary that's responsible for oxytocin and vasopressin, or antidiuretic hormone. Two words for the same structure, or same compound. And then our anterior pituitary up front. So we could actually have overproduction of the pituitary gland. It's pretty common. It's what we worried about with my daughter. And if there was an adenoma, there's a question is which part of the pituitary gland would this be located if you were talking about hyperpituitarism? Anterior, because it's the one that's mainly responsible for the endocrine functionality. And the adenoma is going to be classified by the type of hormone that's being produced. The adenomas typically secrete one type of hormone. Sometimes they can make two, but usually it's just one. And that adenoma, or that growth, that benign lesion, most of them are benign, but they can either be functional, silent, or hormone negative. So functional means they make hormone and has clinical effects. Silent means hormone's produced, but it's not operational, it's not functional. And then hormone negative, no hormone is made. And so they were worried about a hormone negative adenoma in my daughter. Most of these adenomas of the pituitary are benign, and I learned that back then. It still makes you nervous. In the pituitary, their clinical manifestations that typically happen can vary significantly, but the main ones that are broad-based is you get the optic chiasm being impinged because of the location of the pituitary. It sits in proximity to the optic chiasm, and so vision could be impaired. You could have cranial nerve impingement. You could have certain cranial nerves that are influenced as a result of that adenoma. There's 12 cranial nerves. That's 201. Hypersecretion. The hypersecretion would be dependent upon the hormone of how it's going to manifest. Same with the hyposecretion. In the hyposecretion, we talked about this earlier, the tumor could grow to a size where it's putting pressure on the functional part of the tissue, and now their production of hormone actually decreases. Specifically, as it relates to the pituitary gland, growth hormone hyposecretion is one of the most common problems with the anterior pituitary. And that's exactly what they thought was wrong with my daughter. Growth hormone was low, so they thought maybe she was short stature because she didn't have enough growth hormone. She just has small genes. I mean, literally and figuratively. Okay, let's talk about manifestations of growth hormone abnormalities. Giganticism and acromegaly. These are less common, but these would be hypersecretion of growth hormone instead of hypo, like with my daughter. Giganticism and acromegaly. So growth hormone, if it's manufactured in higher amounts, or if it's being released in higher amounts, in childhood, before the growth plates close, it's going to lead to giganticism. You're going to have large statured individuals. So when I was growing up, there was this famous fake wrestler called Andre the Giant, okay? And he had growth hormone due to pituitary giganticism. He had hypersecretion of growth hormone. There's been a number of different celebrities over time, many of them athletes, that have had hypersecretion of growth hormone. Now, once the great growth plates close and the bones and the muscles still respond to the growth hormone, but the bones, the long bones will no longer extend, then you get what's called acromegaly. And so in these pictures, you've got a male example up top with acromegaly, and then you've got a female example across the bottom. So let's first talk about the male example. The upper image, what I want you to pay particular attention to, and you would never be able to identify this individual, even if they were sitting in this room, because their eyes are boxed down. Isn't that amazing? I always wonder why they do that. They're just like, really? Like, I don't think you don't. Who's that? Dr. Keller! Right? Holy crap. But here you have it. Patient with acromegaly, the cheekbones are very pronounced. They're very obvious. The forehead actually is prominent and bulges. The jawline's enlarged. The facial lines are prominent. There's thickening of the frontal lobe itself. Just above the eyebrows, you can kind of appreciate that. Frontal bossing is usually what's that referred to as. So the bones of the skull are responding to the growth hormone, and those bony features are becoming more dense. The growth hormone is not being utilized by the long bones to extend the individual anymore because they've actually closed. Those epiphyseal plates are closed. Now, the bottom picture, so that's a man at the top. The bottom picture is a young woman who did not develop growth hormone abnormalities until later in adult life. And so you can see her as a young woman on the lower left, and likely due to a tumor in the pituitary, started releasing high amounts of growth hormone, and it starts manifesting itself into some of the same types of features in that female as she aged. Okay, she's not going to get bigger, but she's going to have bony architecture that changes significantly. And so this is a progression of this woman over time due to acromegaly. Yes?
How does that happen? Like, I thought that HGH just decreases dramatically once you get older.
Well, but if you have a lesion in the anterior pituitary, and you upregulate the production of growth hormone, then, which is what happened in this individual, then yeah, growth hormone is supposed to go down, but now all of a sudden it spikes up. Yeah, so like target tissues that respond to growth hormone are muscle, bone, and cartilage. Okay, so let's talk a little bit about some of the clinical challenges associated with acromegaly and growth hormone. So growth hormone tends to impair carbohydrate tolerance, so it leads to an increase in metabolic rate. It causes excess blocking or inhibition of peripheral glucose uptake by the cells, and it reduces their sensitivity to insulin. So now the patient becomes hyperglycemic with high amounts of growth hormone circulating around. And with the high amounts of sugar in the blood, they develop what's known as hyperinsulinemia, and they start developing characteristics of type 2 diabetes. Okay? So if you look at these patients, the growth hormone blocks insulin activity by inhibiting phosphorylation of this insulin receptor. And now they reduce their sensitivity to insulin in the periphery, and it causes the body to start producing higher amounts of insulin to respond to it because they're less sensitive, which is classic clinical symptoms of type 2 diabetes. So they develop later in life type 2 diabetes symptoms as a result of this growth hormone abnormality. Insulin-like growth factor 1, so this first bullet point up top, the insulin-like growth factor 1, it's a primary mediator of growth hormones activity. The growth hormone's made in the anterior pituitary, as we talked about. It's released into the bloodstream, and it triggers the liver to make IGF-1. So IGF-1 comes from the liver as a response of growth factor, growth hormone binding to the liver and upregulating IGF-1. Now the liver makes IGF-1. That is what goes out into the periphery and stimulates the body to grow. And it has growth-promoting activity on muscle, cartilage, bone, liver, kidney, nerves, skin, hematopoietic cells, including red blood cells and white blood cells, as well as lung tissue. Okay? And so that's why you see skin changes in this older woman on the lower right. Okay? So that target tissue for IGF-1, skeletal muscle, cartilage, bone, liver, kidney, nerves, skin, blood cell lines, hematopoietic cells, and lungs. Okay. ProlactinOMA. ProlactinOMA, the reason I want to talk about this one is it's the most common hormonally active tumor that we find in the brain. So, again, these are usually benign, and part of the way that you would know that, or you would be suspicious that they'd be benign, is they're making functional hormone. So they can't have mutated too far. Does that make sense? They're contained, they resemble the native tissue, they're making the hormone they're supposed to make, but they're making too much of it. So a prolactinoma is the most commonly hormonally active tumor. So prolactin induces breast tissue development, milk production, bless you, and suppresses, it doesn't bless you, sorry, that was a pause. It suppresses the ovarian cycles, and about 30% of the primary tumors that are prolactinomas actually make prolactin. In women, this is going to lead to amenorrhea, which is the absence of a menstrual cycle, and galactorrhea, which is spontaneous milk letdown. Okay, so they'll make milk. Basically, the body thinks that it's pregnant, and so they will spontaneously release milk even if they're not pregnant or nursing. Now in men, if that wasn't awkward enough, in men it's a little bit more awkward even, because there's typically not much prolactin being made at all in men. So you'll have oligospermia, which is low concentration of sperm in the semen, reduced sexual drive or libido, and erectile dysfunction. So the prolactinoma that's shown here is located on the left right here. And if you take a peek in the pseudocolor, here's our elevated optic nerve. So this optic chiasm could be impinged and cause vision problems. But this is this prolactinoma that's actually highlighted. Pretty large, pretty substantial. MRI view. In this particular patient, there wasn't nerve impingement quite yet. Okay. Hypopituitarism. So these were all hyperactivities of the pituitary gland. If we look at underactivities or low activities, low release of the pituitary, we call that hypopituitarism. Some of the causes could be an infarction of the tissue. Patient has a stroke. The anterior pituitary is underperfused with blood. Now you have an infarction or dead tissue, scarring of the anterior pituitary. It no longer manufactures the hormones that it was supposed to previously. Okay? Traumatic brain injury, post-car accident, for example. Infections, or even surgical damage. What's surgical damage? Why? Well, if you had a lesion, like a prolactinoma on the previous slide, and the surgeon decided to go in, cut out the lesion, take some of the healthy surrounding tissue just to be safe. They took too much. Now all of a sudden, instead of overproducing certain hormones, now you're underproducing. Okay? There's one in particular that's interesting, which is known as the Sheehan syndrome. And so it's a well-known fact that the size of a woman's brain increases during pregnancy. It's actually not a joke. Particularly the pituitary gland is bigger. That's the endocrine organ. Bless you. That's the endocrine organ, and so the vascular perfusion of the pituitary swells. and it increases in size due to the hormone activity that's necessary to support two organisms, right? So post-delivery, if there's rapid blood loss, a lot of hemorrhaging that takes place during delivery, which does happen, there could be significant reduction in blood flow to the enlarged vasculature of the anterior pituitary. And so you can actually have an ischemic episode known as Sheehan syndrome, postpartum hemorrhage in females that can cause an infarct in the pituitary gland. So it's been pretty well described, and that's why we call it Sheehan syndrome. And it's only affecting a subset of postpartum women. Okay? Okay, the last one that I want to characterize up in the pituitary, and then we'll move more distally. Okay? Yes, sir?
So when you say postpartum, does that mean after birth?
Yeah, right after birth. So after delivery, if there's a lot of hemorrhage, a lot of blood loss, then you would have a risk of the blood volume dropping. And if the pituitary gland had enlarged, it required a lot more blood flow, and you lost a lot of blood, it's going to be at risk of ischemia very quickly, because it was kind of, enjoying high levels of perfusion, and now all of a sudden it's starved. You with me? Okay. So the last one is on the back side here. We're at the pituitary, but now we're posterior pituitary. It's the only example of the posterior pituitary that we're going to talk about. And this is diabetes insipidus. And I'm talking about it now because we're going to talk about diabetes mellitus later. And they're very different, but they sound very similar, okay? So diabetes insipidus. In the Latin, diabetes means to siphon, and insipidus means without taste. So you're siphoning off taste. That's what this disease literally translates from the Latin. Siphoning without taste, okay? So this is a disease of the posterior pituitary, diabetes insipidus. It's not nearly as common as diabetes mellitus. They're not even remotely related. I know they sound similar, but they're nothing alike. We'll talk about diabetes mellitus later. It might be on the next exam. We'll see how far we get, okay? But with diabetes insipidus, there's under secretion of ADH, or vasopressin. ADH is antidiuretic hormone. And antidiuretic hormone has activity on the kidneys, and it helps to conserve water. And so now, if you don't conserve water, you lose it at the level of the kidneys, and you pee it out. You excrete it in the urine. So the symptoms of diabetes insipidus are polyuria, that's excessive urine, polydipsia, excessive thirst, and hypernatremia, that's elevated sodium in the blood. Because you've excreted a lot of your water, urinated it out, and so now you have too much sodium in the bloodstream. And I'll get your question in a second. Okay? How does this happen? There's two main forms, neurogenic and nephrogenic. So neurogenic is the most common form. That means that it's at the level of the posterior pituitary. It's typically referred to as central diabetes insipidus, and that's a lack of vasopressin or a lack of antidiuretic hormone being made by the posterior pituitary. Why would it not be making it? There could be a lesion there. Okay, there could be an adenoma that's forming in the posterior pituitary, and it's silent. It's non-functional. It doesn't make hormone that works. Okay? The less common form is nephrogenic, but it's very common in end-stage renal failure. So patients that have end-stage renal failure end up developing diabetes insipidus due to the inability of the kidney to respond to the vasopressin that's being made by the brain. instead of conserving water, they lose it. Okay, so nephrogenic is targeting the nephron, which is at the kidney. Neurogenic, the more common form, is targeting the neuron, which is the brain, that's the posterior pituitary. Does that make sense? Question?
So is this type 1 or type 2?
Neither.
Neither? Okay.
This is diabetes insipidus.
Okay. And then could you say those 3 words again?
Polyuria, polydipsia, and hypernatremia. Okay? Don't think type 1, type 2. That's the other kind of diabetes. Okay? We're going to get there, but we're going to separate it in the lecture significantly so you don't mix it up. All right. Let's move to the thyroid gland. So that was up at the anterior pituitary, and then we ended on the posterior pituitary. You guys with me? Now we're moving down into the thyroid. The thyroid glands. We're not going to cover all the organs of these axes, but we're going to get to some of the main ones. This is the one that, my daughter wrestles with. Hyperthyroidism is the first one. Now, she's not hyperthyroid, she's hypo. So, hyperthyroidism, thyrotoxicosis. This young man is wrestling with hyperthyroidism pretty aggressively, I would say, right? The primary causes of hyperthyroidism can either be a toxic goiter or Graves' disease or an adenoma. So let's start with adenoma because that's where we came from. So you can have a lesion at the thyroid, a mass, and it mimics the thyroid tissue and it hypersecretes thyroid hormone, T3 and T4. That is what regulates your metabolism. You with me? So if you overproduce thyroid hormone for a long period of time, you burn all of your energy very quickly. And so this young man can't eat enough food to keep weight on. Okay? A second way that this could be manifested is Graves' disease. Graves' disease, you guys remember that? That was, what type of hypersensitivity was Graves' disease? I think you're guessing. Yeah, honestly. It's a type 2 hypersensitivity where the thyroid is overactive because of the autoantibodies to the TSH receptor. You guys remember that? That picture, that diagram? This is a great review question. A great example of how a review question might show up in 2 weeks. Because this is a type 2 hypersensitivity, and now we're talking about endocrinology, right? So the TSH receptor, you have an autoantibody that binds to it and stimulates it. So now you stimulate the thyroid hormone to be made, even though you're not supposed to. So Graves' disease is a type 2 hypersensitivity. Then the last one is a toxic goiter, whether it's a single or it's a multi-nodule. And a goiter actually spans a broad spectrum of different types of etiologies. But for all intents and purposes, these goiters that form on the thyroid gland is swelled tissue of the thyroid that enlarges the thyroid and can start stimulating an overproduction of thyroxine, or T3 or T4. So triiodothyronine is T3 and thyroxine is T4. Now you make more thyroxine than you make triiodothyronine, or T3, but T3 is much more biologically active than T4. But both of them come from the thyroid gland. And then secondarily, you could be in a hyperthyroid situation because you've got too much TSH coming from the anterior pituitary. So if the thyroid is here just in the neck, and the pituitary gland is making TSH, you need to, and the result of the patient is this picture here. You say they're hyperthyroid, but this was like the situation with my daughter. She was hypothyroid. But if the thyroid is here and it's controlled by the pituitary, which is controlled by the hypothalamus, if you see this, you don't immediately know if it's a thyroid problem. You guys with me? You don't know. You can scan the thyroid and it can look clean. And then the question is it coming from a adenoma in the pituitary? And so you don't really know where you are until you start digging into the axis. And you have to know what that normal flow of endocrinology is for you to figure this out. And if it's not at the level of the anterior pituitary, where else could you look? The hypothalamus. You could look above that. Okay? So you kind of have three different levels that you have to try to go figure out. Like a cardiologist tells you something's wrong with your heart. Thanks, gosh. Pretty obvious, right? Endocrinologist, it's like, don't know yet. We got three possible places to look. What the? Do you not know what you're doing? No, it's actually really complicated. You guys with me? No dig against cardiologists, but endocrinology is a very difficult subspecialty.
So you said with elevated metabolism. So even if he were to consume a lot of food, what would happen to that food exactly?
It gets burned up. Yeah, the calories get burned. They get used.
Used to do what exactly? Like
Maintain life.
There's no.
He looks like he's starving, right?
Exactly. There's no muscle growth. There's no bone
Yeah.
growth. Nothing.
It's
So
just
what's
barely
happening
keeping him
to all the
alive.
food?
Yeah. What's that?
I said there's no muscle growth. There's no bone growth. There is no anything that is showing that there's birth food. So even if you were to eat a lot of food, what would happen to it? It would just like what would happen to it? Just disappear for it?
Well, he's consuming high amounts of food just to stay alive because his metabolic rate is so high.
So
Okay.
it's base metabolism.
His basal metabolic rate is high. That's what T3 and T4 control, is your metabolic levels. Yeah.
Is it called an adenoma, whether it's in the thyroid or the hypothalamus or pituitary?
Is it called
Is it
adenoma?
called an adenoma?
Yeah, so it's referred to as, that's an option
There
here.
could be a lesion here or there.
It could be a lesion in any one of those locations. Adenoma is a general term. It could be an adenoma in the hypothalamus, the pituitary, anterior pituitary, or it could be an adenoma on the thyroid. Okay? And a lot of times when there are adenomas or spots on the thyroid, they'll go in and surgically remove them. It's very common. And they might even remove the entire lobe. There's 2 lobes. Okay? And I have a good friend who was hyperthyroid. My daughter was hypo. He was hyper. He had lesions on his thyroid. So they took half the thyroid out. And he was still hyper. So they took the other half out. So he has no thyroid. And now he's on medication just like my daughter. They're like twinsies. They both take. He's like 6'5", so his pill's a little bit larger than my daughter's. But yeah. So that's a surgical reduction of the thyroid that he went from hyper to hypo. Does that make sense? This is actually pretty common. Thyroid cancer lesions are pretty common. And they call it thyroid cancer and it is a form of cancer and it's very nervous because you don't know what's going on. But the prognosis, the outcomes are usually very good with thyroid cancer. Okay? When my good friend was going through it, like all the oncologists said, saying, well, if you're going to get cancer, this is the kind you get. This is the good, and he's like, that doesn't make me feel better, right? It was not, the bedside manner wasn't all that great. So those of you that are going to be future docs, work on that delivery a little bit. But I understand what they mean, right? Academically, I understand what they mean. They just didn't deliver it very well. It's like, you just told me I have the C word, and you're telling me I should be happy about it, right? So, okay, so I haven't gotten to this next picture. So this is July 7th of 2008. You see this young man. And in this particular case, it wasn't surgery that they did. They actually gave a thyrostatic drug known as carbimazole. Carbimazole is a thyrostatic drug that actually kind of poisons the thyroid gland, slows down its activity, And you can see this is an international date stamp, so it's month, day, or sorry, day, month, year. So it's the 29th day of December 2008. So, I mean, basically it's 5 months later from when the top photo was taken. And that's how dramatically he's recovered, by having a thyrostatic prescription, okay? All right, Graves' disease. What type of hypersensitivity? Oh, very good. It's like you studied. That's amazing. That's very impressive. Okay. Type 2 hypersensitivity, you make autoantibodies to TSH, to the TSH receptor, excuse me, to the TSH receptor. So they get stimulated to trigger on, and they make the thyroid more active. And so Graves' disease is a secondary type of thyrotoxicosis or hyperthyroidism. But the manifestations can be a little different. So you got hyperplasia or enlargement of the thyroid, that's trophy of the thyroid. Hyperplasia, hypertrophy of the thyroid. You've got this pretibial myxedemia. It's a little bit of a rarer symptom, is what's shown on this slide. But you have these sort of lesions that form on the skin. And these lesions that form on the skin are kind of a dermatological condition that is in conjunction with the systemic manifestations of Graves' disease. So that's usually a sign that the patient has been dealing with Graves' disease unmanaged for a long period of time. And they get kind of these skin lesions right on the tibial crest, basically the shin, from the knee all the way down to the ankle. Okay? They also have this eye disease and significant weight loss. This eye disease, or this bulging eye disease, is shown on this slide. A very classic manifestation of Graves' disease. And this is the same diagram that I showed you back when we talked about the hypersensitivity lecture. Right? We talked about 2 examples with type 2 hypersensitivity. We talked about Graves' disease, where we got autoantibodies against the TSH receptor. This is at the level of the thyroid, and it triggers thyroid hormone to be made. Okay, that's Graves' disease. And the second example we talked about way back when was the myasthenia gravis, right? That's different. That has nothing to do with this lecture. But this should be familiar to you. So we move from hyperthyroid to hypo, right? And this is what my daughter was wrestling with, is now you have an underactive thyroid gland. Underactive thyroid gland versus overactive. So you make anti-thyroid antibodies. That's the primary. There could be an infection, thyroiditis. It's usually a bacterial contamination. Or there could be an endemic type of goiter where the tissue enlarges, but it doesn't enlarge to produce functional thyroid, like you see in an adenoma. You get the endemic goiter, which is usually an indication, or it's closely in association with more poor countries. So in poorer countries around the world, we see these endemic goiters that actually show up, and they trigger hypothyroidism. Versus the goiters over with hyper is an enlarged adenoma that's a swelling or an enlargement. That's all a goiter is, an enlargement of the thyroid. But that enlargement is due to tissue that's active. The endemic goiter is due to poor dietary capabilities in usually third world countries. So the thyroid gland requires iodine for its function. And iodine for its function. And iodine is a nutritional supplement that's found in a lot of different foods that you and I take for granted. We get it in seafood, like tuna and cod, seaweed, eggs, and milk. All have daily levels of iodine in them. And years ago, the Food and Drug Administration in this country recognized the concern about an endemic goiter due to dietary limitations of iodine. And so they decided to fortify a enhancement of food products that Americans love, and salt. And so you can get iodized salt from the grocery store, and that is to prevent the American population from having dietary restrictions of iodine, okay? Iodized salt. So this goiter is because the thyroid gland is not working correctly, and it doesn't have the iodine that it needs, and so it enlarges and swells to try to compensate for it, okay? But it's not able to keep up. In fact, one of the reasons I told you that thyroid cancer is fairly, the prognosis is quite good, is because we can take chemotherapy agents, right? We can take chemical agents that target and kill cells, and we can make them, we can load them with iodine, and then the only cells in the body that will take up the chemotherapy agent are what cells? The thyroid, because it's the only tissue in the body that requires iodine. And so that's why targeted chemotherapy for thyroid cancer works very well, because all you got to do is load it with iodine, and then the thyroid is the only one that will take it up. Okay? Yeah?
So does that chemotherapy like only work good in patients who don't have conditions like this?
Yeah, so this patient is pretty advanced.
So like say you did have a thyroid condition, would your like chances of surviving thyroid cancer be?
I mean, earlier detection, survival rates go up, but it's still a fairly good prognosis as far as cancer is concerned for treatment anywhere along the cycle. Yeah. You know, we didn't let my daughter get this far gone. You know, it was more of the pediatrician on annual visits was watching her growth charts and thinking, she's really not, she was on her own curve, which was fine, like down at the very bottom, but then she started falling off of her own curve, and that's when the pediatrician was like, she was on her own curve, but now she's leaving her own curve, and so I want to do some blood tests, which is the right thing to do. I mean, I completely agree, and we still have that pediatrician. She's amazing. But yeah, it just freaks you out as a parent. Like, what's going on here? Right? So, and then there can be a congenital defect, of course, in the thyroid gland that cause problems. Secondary problems can be anti-thyroid drugs. Right, so like the previous young man that we showed. So you can have thyrostatic drugs that go too far, or you can remove the thyroid to slow it down, and you can stimulate hypothyroidism, like what happened with my friend. And that's the second point here, is loss of thyroid tissue after hyperthyroid treatment. So in these lectures, we are hopping around between overproduction and underproduction. Over-regulation, under-regulation. You correct this behavior, now you stimulate this behavior, right? Or you correct this manifestation, and now you trigger something else. And so there's never this one-size-fits-all situation in endocrinology. And then on this last example that I want to talk about as it relates to the thyroid is Hashimoto disease. So Hashimoto disease is really the most common type of hypothyroidism, and it's more common in women than in men. It usually presents as painless thyroid enlargement with slight hypothyroidism in middle-aged women, and it's a autoreactivity of CD4 positive helper T cells. Hashimoto's disease, though, is a type 4 hypersensitivity because of the involvement of the T cells, right? And the involvement of the T cells here, where here's our thyroid epithelium, so you have T cell sensitivity to thyroid antigens, and you start activating macrophages to cause injury, CD8 cytotoxic T cells to stimulate T cell mediated cytotoxicity, as well as stimulating antibodies to be produced. And so if the antibodies are being produced, and that would lead you to believe that maybe this was a type 1, 2, or 3 hypersensitivity, but we know that if there's any T cell involvement, like cytotoxic T cells or helper T cells, that we would classify these as type 4 hypersensitivity, correct? So Hashimoto disease is a hypersensitivity of class 4, type 4, where you're targeting destruction of the thyroid gland all on your own, right? Your immune system is trying to destroy it. Most common type of hypothyroidism, okay? So in the hypothyroidism clinical manifestations, this young lady, untreated on the left, she was a 10-year-old female. She had poor growth. She was relatively obese for her age. And she was very immature, like from a denture or a dental standpoint. She hadn't lost a single deciduous tooth by the age of 10. So all of her baby teeth are still in. She was treated, and within the next 10 months, she lost 6 teeth. She had a striking catch-up in growth. The bone age caught up, and you can see the results over on the far right. So hypothyroidism on the left picture. So she's going to have the symptoms that are listed here, where she's going to have weight gain. She's going to be very low energy or listless. Cold intolerant. She's going to be cold to the touch. Her body's not going to be able to thermoregulate very well. Constipation, fluid in the tissues. There could be a lot of pericardial effusions. That's fluid around the heart because there's a lot of edema that's not making it back into the bloodstream. And left unchecked, that could actually progress to heart failure later in life if you don't do anything about it. And this congenital hypothyroidism, another name for it is actually called creatinism. So you might see that term show up maybe on the exam or in one of the post quizzes. Creatinism, that's hypothyroidism, and it's typically referred to it in children. So the primary diagnosis here is looking at TSH. And so I'm asking this question as to why. Well, a low TSH level, the thyroid is likely overactive, so you've got hyperthyroidism. So if you have less TSH being released by the anterior pituitary, it's in efforts to try to control the thyroid hormone levels. Okay, so if the thyroid itself is not making enough hormone, right, it's underactive hypothyroidism. The body's response is to have the anterior pituitary make more TSH to tell the thyroid to do something. So typically, hypothyroidism is diagnosed, or this cretinism is diagnosed, congenital hypothyroidism is diagnosed by measuring TSH levels from the anterior pituitary. And they usually go up by 4 to 5-fold what they're normally supposed to be. Because the pituitary is trying to tell the thyroid, get going. Make sense? Okay. So we're going to pause there. This is where we're going to end. We're not going to have time to get into diabetes mellitus, but that's good because then you won't worry about mixing them up on this exam. So we'll get into the pancreas after the second exam. Okay? Does that make sense? Diabetes insipidus is what you need to know for this exam.